Good afternoon. My name is Dr. Sheikh-Fayyaz. I'm Associate Professor at Hofstra Medical School, affiliated with Northwell Health Laboratories in Long Island, New York. Today my topic is intravascular B-cell lymphoma of breast. I'm presenting this case as it is a rare entity and early diagnosis determines the prognosis. 58-year-old female with good performance status, presents with thickening of overlying skin, suspicious for lymphatic occlusion and a possible early inflammatory carcinoma. No family history of breast cancer, screening mammograms unremarkable. On examination, lesion appears to be non-mobile, fixed to breast parenchyma, irregular and hard. Imaging studies show category 4 lesion. Initial mammogram shows increased parenchymal density in the upper outer breast. Ultrasound shows indeterminate complex lesion at 8 o'clock. On MRI, there are two circumscribed nodular densities and asymmetric densities in the right breast. Ultrasound also showed complex cystic lesion fluid at 9 o'clock. Mammogram shows increased parenchymal density. Another view showing increased parenchymal density. MRI shows asymmetric skin and trabecular thickening. Asymmetric non-mass enhancing lesion involving the upper outer breast. Ultrasound shows diffuse parenchymal edema with hypoechoic lesions. Patient had MRI guided biopsy of the right upper outer non-mass enhancing lesion, right lateral retroareolar lesion and right lower inner mass. Histopathology shows benign ductal ducts lined by benign ductal epithelium, increased vascularity and nodular proliferation of these blue cells. Another area shows benign ducts lined by benign ductal epithelium, increased vascularity and nodular proliferation of these blue cells. Another area shows benign ducts, and in addition there are nodular proliferation of these blue cells. What I'm trying to emphasize is that the ductal epithelium in the breast is benign. In the fatty tissue surrounding the breast, you can see very extensive nodular proliferation that consists of blue cells, and these blue cells are confined within these spaces. Higher magnification show that the neoplastic cells are large cells with prominent nucleolus and are mitotically active as seen here. This slide shows a contrast between the two types of large cell lymphoma. Intravascular large cell lymphoma, the neoplastic cells are confined within the vascular spaces, and in diffuse large B-cell lymphoma, there are sheets of large cell. In this case, a battery of immunohistochemical stains were performed. Pan-cytokeratin, which stains the epithelium, shows here nicely outlining the epithelium and is negative in the neoplastic cells. T240, which stains the endothelial cells, here you can see them outlining the endothelial cells and higher power showing the endothelial cells. The neoplastic cells are confined within the vessels. The neoplastic cells showed B-cell phenotype. CD20 is a B-cell marker and the neoplastic cells are positive for B-cell. PAX5, which is a nuclear stain for B-cell lineage, these neoplastic cells are also positive for PAX5. CD10 and BCL6 are germinal center cell markers, and as you can see here that these neoplastic cells are negative for CD10 and they are DIM positive for BCL6. BCL2 is a regulator of apoptosis and stains the T lymphocytes. Here you can see the bright staining. In addition, they are showing dim staining of the neoplastic B cells. This is an aberrant expression. MUM1 is a late germinal center marker or a post-germinal center marker, and the neoplastic cells are positive for MUM1. Ki67 is a proliferation marker, and these cells are expressing Ki67 at almost 90%. These neoplastic cells are also positive for c-MYC. One should approach a biopsy with open mind and think out of box. A biopsy of the breast can show primary carcinoma, ductal, lobular, or metaplastic, or a metastatic lesion, a melanoma, or epithelioid angiosarcoma, or even lymphoma. Based on morphology and immunophenotyping, a diagnosis of intravascular large B-cell lymphoma is made. There are few cases of intravascular large B-cell lymphoma of breast reported in literature. These are another two cases reported in literature of intravascular large B-cell lymphoma. This table shows 3 cases reported in literature. The age range is 60 to 80. All these cases were reported intravascular large B-cell lymphoma. Al-Akil in this study reported synchronous ductal carcinoma in situ. Treatment is unknown and patient was lost for follow-up. Ho et al. Reported synchronous invasive ductal carcinoma. Mastectomy was performed. Patient treated with R-CHOP but died in 2 weeks of starting the chemotherapy due to tumor lysis and renal failure. Montario et al. Reported no synchronous ductal carcinoma and patient was treated with CNOP but died after 9 months of starting chemotherapy. So this clearly indicates that the intravascular large B-cell lymphoma is an aggressive disease. Early diagnosis is important for prognosis. Now I'm going to discuss intravascular large B-cell lymphoma. Intravascular large B-cell lymphoma is a rare type of extranodal large B-cell lymphoma characterized by selective growth of lymphoma cells within the lumen of vessels, especially capillaries, and they spare the large arteries and the vein. First time reported in 1959 and was called as angioendotheliomatosis proliferans systemista. And they thought that these are the cells that are arising from the endothelial cells. Common clinical features include pyrexia of unknown origin, generalized fatigue, cutaneous lesions that can include rashes, plaques, nodules, ulcers, and hyperpigmentation. Neurological changes can manifest as altered consciousness, sensory motor deficit, seizures, paresis, and dementia. The most frequent mammographic appearance is a well-circumscribed, uncalcified mass. Other radiological features include amorphous or speculated uncalcified mass and diffusely increased parenchymal density. Ultrasound usually reveals hypoechoic lesions with well-defined borders that lack significant posterior enhancement or acoustic shadowing that may be confused with benign cyst. There are 3 types of clinical presentation. Classic form is seen in Western countries. Symptoms are related to organ involved. Neurological or cutaneous symptoms are seen. B symptoms are also common. Endocrine insufficiency involving the adrenal gland is seen in 67% of cases. In lung, you can have ground glass appearance. Hemophagocytic lymphohistiocytosis is rare. Asian variant is characterized by hemophagocytic syndrome associated with multi-organ failure. Hepatosplenomegaly, pancytopenia, and bone marrow involvement is seen in 73% to 100% of cases. B symptoms are also seen and causes rapid progression, and median survival is 2 to 8 months. The third type is isolated cutaneous variant, seen in 25% of cases. Median age is 59 years old, commonly seen in females. CBC is normal and seen in Western females most frequently. Restricted to the skin, can be a single or multiple lesions. The number of cutaneous lesions derives the therapeutic choice. Systemic symptoms are seen in 30% of the cases and shows better prognosis. The reason for better prognosis in this variant is not completely understood, but it is likely that an early detection and therefore an early therapeutic intervention in patients with cutaneous disease may be cardinal. Diagnosis can be made by skin biopsy of the lesion or normal skin and transbronchial lung biopsy. Histopathologically, lymphoma cells are within the vessel. They are large cells with prominent nucleoli, open chromatin, and frequent mitosis. Cells can have anaplastic features. Rarely, there are small cell variants which can be confused with low-grade B-cell lymphomas. Fibrin, thrombi, and necrosis are also seen. Histopathology shows that the cells are large, some have prominent nucleolus, and show multiple mitosis. With the exception of major vessels, almost all blood vessels could be involved by intravascular large B-cell lymphoma. There are three different growth patterns that can be recognized in this type of lymphoma and usually coexist in the same sample or patient. In the discohesive pattern, the lymphoma cells are preferentially within the central portion of the blood vessel and exhibit free-floating appearances, whereas in the cohesive pattern, neoplastic cells almost completely fill the lumen, and in the less frequent pattern called as marginating, because the tumor cells are preferentially adherent to the endothelial cells and leaving the central portion of the lumen free. This is a marginating pattern in which the lymphoma cells are adhering to the endothelial cells. This is an example of discohesive pattern in which the neoplastic cells are within the lumen of the vessel. And this is a cohesive pattern in which the lymphoma cells are stuffing the vessel and they are completely occluding the vessel. CNS recurrences may show extravascular masses. Sinusoidal involvement is seen in liver, spleen, and bone marrow. Peripheral blood can show occasional neoplastic cells. Immunophenotyping shows that the neoplastic cells express B-cell antigen CD20, PAX5, CD79A. CD5 positivity is seen in 40% of cases, CD10 in 15% of cases. Most of the cases are CD10 negative and MUM1 positive. BCL6 and CD5 positivity is seen in 20% of cases. High Ki67 is common. Differential diagnosis includes intravascular NK T-cell lymphoma EBV positive, intralymphatic anaplastic large cell lymphoma ALK negative. The diagnosis is made based on the morphology and immunohistochemical markers. Intravascular large B-cell lymphoma shows complex karyotype. Claremont et al. Reported that chromosome 1 is most commonly involved, and in addition followed by chromosome 3, 6q, 14, and 18. Gene mutation analysis has shown mutation in PIM1, MYD88, CD79B, PRDM1, BTG2, and EZH2 loci. Immunoglobulin genes are clonally rearranged. The question arises, why are the tumor cells confined to the vessels? Intravascular large B cells express molecules involved in cell migration and molecules that make them capable of adhering to the endothelium but lack those that are involved in extravasation. There are multiple theories to explain confinement of lymphoma cells within the vessel. Expression of chemokine receptor CXCR3 on tumor lymphocytes and its ligand CXCL9 on endothelial cells are involved in the regulation of lymphocyte trafficking and integrin activation as proposed by Cato et al. In this case, the intravascular large B-cell lymphoma, they do express CXCR3 on tumor lymphocyte, however, its ligand CXCL9 is absent on the endothelial cells. A number of homeostatic chemokine receptors such as CXCR5, CCR6, and CCR7 are decreased in intravascular large B-cell lymphoma, which act on lymphocyte migration across the vascular structure. Homing receptors are the adhesion molecules. Lymphoma cells lack CD29 and CD54. Sural et al. Have shown marked expression of angiogenic factors including VEGF-A, VEGF-C, FIGF, and SPP1 in a case of cutaneous intravascular large B-cell lymphoma compared to other types of diffuse large B-cell lymphoma, which may explain the apparent tropism of intravascular large B-cell lymphoma to vascular neoplasms, including benign hemangiomas. Prognosis of intravascular large B-cell lymphoma is poor and is an aggressive lymphoma. Good prognosis is seen if limited to skin. Intravascular large B-cell lymphoma is an aggressive disease with fatal consequences if the diagnosis and treatment are delayed. Unfortunately, patients commonly present in an advanced clinical stage. Mastectomy does not add survival benefit. Dose-adjusted rituximab EPOCH protocol. The use of rituximab has significantly changed the evolution of intravascular large B-cell lymphoma, showing better prognosis, 3-year overall survival rate of 60 to 80%, complete remission rate 88%, overall response 91%. Single cutaneous lesions of intravascular large B-cell lymphoma can be managed with radiotherapy in elderly patients with contraindication for chemotherapy. Radiotherapy should be used only for palliative purpose. CNS relapse is seen in 25% of cases. Neurolymphomatosis is serious complication. Methotrexate intrathecal or systemic high dose is given. Neither the clinical type of presentation nor clinical parameter predicts CNS relapse. Autologous stem cell transplantation has been shown to be effective in young patients with good performance status.